My name is John Mathias, and I help to run the MPN Advocates Network. I'll be formally welcoming everybody to the meeting later on today after lunch. But in the meantime, welcome. Thank you very much for coming. Some of you I know have come a very, very long way to be with us today. Now, the idea of this introductory session was to make sure that everybody who's here at the meeting is kind of on the same page and has got a really good basic grounding in what MPNs are, and to have a good basic understanding so that going into the rest of the meeting, everybody is at the same kind of level of understanding of the illnesses and the treatments, etc. Now, in order to do that, we couldn't really have a better speaker than the man on my left here, Dr. Martin Ellis, who's joining us from Israel, where he practices as an MPN specialist, and is also very closely involved with the MPN patients group in Israel called Flute of Light. He asked me not to give a lengthy introduction, so I won't say anything more other than simply to hand over to him. Dr. Ellis.
Thank you very much, John, and thank you all for being here, and thanks to Giora and the organizers for giving me the opportunity to speak both this morning and later on. I asked John not to give me a lengthy introduction so that I could give you a lengthy introduction about who I am. As John has said, I'm a hematologist. My main area of clinical interest is myeloproliferative neoplasms and thrombosis and hemostasis, which deals with blood clotting, which is a very important part of myeloproliferative neoplasms. And I have the honor at the moment to head our MPN working group in Israel as part of our Society of Hematology. What I have prepared this morning is a fairly extensive, comprehensive review of what I thought would be important information to have for the people in the room. I must warn you that there are quite a number of slides, some of which I'll go over slightly more quickly than others, some of which are repetitive in order to try and emphasize a certain point and perhaps explain it from more than one direction. There are quite a lot of clinical images. And I'm saying all of this just to remind myself to tell you that these slides will be available to you, and if you find that they're useful, then you can certainly use them as a resource. Clearly, in 1 hour, which is the time that I'm allotted to speak to allow us time for questions, it's really impossible to start from 0 and get to 100 as far as MPNs are concerned. I'm also not exactly aware of what the start-off point for each person in the audience is, if there are people that have no background at all in MPNs, and I'm sure that there are people here that have a fairly advanced working knowledge of MPNs. So I'm going to try and pitch it somewhere where I think would be in the middle. It's a relatively small group, but a big room. We can make it interactive if people would like to do so. So if I say something that is completely not understood, please raise your hand and I'll try and address a particular point. Otherwise, as I said, there will be time for questions at the end of my presentation. So this is the medical school at the Tel Aviv University. It's a beautiful campus. But if you're looking for medical students, that's probably where you'll find them, short way away on Tel Aviv beach. The outline for the talk is really in front of you over here. There are going to be two parts to this talk. The first part looks at a little bit of physiology and the way that things work normally, and then what we call pathophysiology, which is the way things work abnormally as far as myeloproliferative neoplasms are concerned. This is a little bit of heavy stuff, but I think that it's very, very important, as you will hear from me and from others during the next couple of days, to understand something about the molecules, the DNA, the genetic abnormalities that are present now in all the MPNs, essentially, and to a very great extent. So we will spend some time defining these, explaining these, and giving you at least the toolbox and the dictionary so that you can have some understanding of the terminology that's used perhaps later on during the meeting. I will then focus on three of the main myeloproliferative neoplasms, MPNs, that we will be dealing with. I assume that we'll be dealing with these three almost exclusively during this meeting. And for each one of these diseases, polycythemia vera, essential thrombocytosis, primary myelofibrosis, which I'll refer to variably as PV, ET, and MF. I think you may be familiar with those abbreviations. We'll go through some of the key features of these diseases, the incidence, how often it occurs in the population, what do the patients look like, what do they complain of. We'll look at the laboratory abnormalities that may be associated with this disease, how we treat these patients, and very importantly, what is the natural history or the course of disease and the prognosis, and how does that vary from patient to patient for each of these three diseases. Well, we're talking about bone marrow diseases, so this is a diagram of a bone, as you can see, and the bone is made up of a variety of tissues, but right in the middle we have the marrow. That's where we're focusing now. And the marrow itself is a very complicated place anatomically and physiologically. There are a number of different cells that are in the bone marrow. We're going to focus on the hematopoietic cells, which are the blood-forming cells, but it's becoming more and more important to focus on the cells that support the hematopoietic cells, called stromal cells or support cells. These are a variety of cells that do not become blood cells, but they're supporting giving a supportive environment for those hematopoietic cells to develop, the blood-forming cells to develop. Incidentally, bone marrow is found in all the bones of a child. However, as we get older, and by the time we reach adulthood, we have active bone marrow in the middle part of our body. In other words, in our ribs, the breastbone or the sternum, the vertebra, and the hips. Our long bones of our limbs do not have active bone marrow in them by the time we reach adulthood. Okay, the first complicated slide, but we'll simplify it. Follow me, please. In the middle, the pluripotent stem cell. Pluripotent stem cell implies that this is the originator cell in the bone marrow, which has the potential to develop into any one of the three main kinds of cells that we have in our peripheral blood or in our circulating blood. I'm sure that you're familiar with these cells. We'll start at the bottom over here. These are white blood cells. Some of them are called granulocytes because they have granules in them. The others are monocytes and lymphocytes. So we have 5 types of white blood cells in our peripheral blood. They're mainly colored over here in yellow with their various names appearing here. Now these cells come from somewhere. In the bone marrow, their ancestor cell, as is the case for all blood cells, is this pluripotent blood cell. Pluri means that it can become anything. It has the potential to become anything. In this case, we're looking at a stem cell that is destined to become one of the white cells in the peripheral blood. This happens because of the variety of chemicals called cytokines that act upon various stages of development of these cells. So from a very primitive, undefined cell, we get a mature cell with a very specific function that will circulate in our peripheral blood. This over here is happening in the bone marrow. However, a pluripotent stem cell could, for reasons that are unknown to scientists at this point, not go down this path to become a white blood cell, but it could take another path influenced by other chemicals. This is erythropoietin, a hormone. And in this case, the pluripotent stem cell becomes a red blood cell. Again, there are stages of maturation from the pluripotent stem cell to the red blood cell that occur in the bone marrow, and it's the final product, the red blood cell, that escapes from the bone marrow compartment and enters the blood, so that when you have a blood drawn from a vein, in the tube, we have these mature red blood cells, and we do not have the precursor or early cells that are found in the bone marrow. And for the third example, a pluripotent stem cell may take another route altogether and develop into a megakaryocyte, which is the precursor cell for the platelets. So here we have the 3 types of blood cells, the platelets, the red blood cells, which carry hemoglobin, and the white blood cells. I think you know that each of these cells has a different function. Physiologically, the white cells are part of the immune system, the red cells are oxygen-carrying cells, and the platelets are involved with blood coagulation. Now, the magic about the pluripotent stem cell is that when this stem cell divides, one of the copies is slightly different to the other. And that's unique among cells. When any of our cells divide, a process called mitosis, the 2 daughter cells are identical. Not so with a stem cell. When a stem cell divides, one copy is slightly more mature. It is committed. There has been a decision that's been made mechanistically in which direction this stem cell is going to develop. The other copy, however, remains a pluripotent stem cell. So it's a self-renewing cycle. Otherwise, we'd divide all our stem cells and then they'd be finished because all the stem cells would have matured into mature cells. After a period of time, we'd have no stem cells left. So fortunately, this is a self-replicating population of cells where the mitosis gives us two different cells, very, very slightly different, subtle differences, however, very important because the one copy will go on to be one of the mature cells, whereas the other copy will be a pluripotent stem cell that can divide again. This is what it looks like schematically. So we have our multipotent or our pluripotent stem cell over here. Cells work in general, and this will become very important later, because they receive a message which is usually a chemical of some sort. It could be a hormone or a cytokine, and you'll see many examples later on. And this message, which is circulating in the blood, in the plasma, it's usually a protein, will attach itself to a receptor. The receptor is also usually a protein structure, and that receptor has a signal transmission mechanism, which is basically a bunch of enzymes, which themselves are proteins, that passes a message on and on and on in the cell until eventually the message reaches the nucleus. The nucleus is really where the machinery exists, the DNA, the chromosomes, to allow that cell to either replicate, proliferate, mature, or die, depending on what message the nucleus receives. So this is our multipotent stem cell. It has a receptor. The specific receptor on the multipotent stem cell is unknown. You may have heard reference to things like c-KIT, CD34. Those are proposed receptors on the peripheral, on the bone marrow stem cell, which activate them, but the true answer is as yet unknown. But something stimulates something, and the result is that we get this mitosis, and we get these precursor cells that are now destined to become other cells. And now, depending on what these cells express, for example, here's a cell that expresses a receptor called granulocyte colony stimulating factor receptor. This particular cell is going to go on to be a neutrophil. Here's a cell that's got granulocyte macrophage receptor. This is going to go on to be a monocyte or a lymphocyte. Here's a receptor called MPL, myeloproliferative leukemia. This is going to become a megakaryocyte, and finally, a whole bunch of platelets. This has got the erythropoietin receptor. This is going to become red cells. So this is how the process works from our multipotent or pluripotent stem cell to our mature cells that we have in the peripheral blood. That's normal hematopoiesis. Abnormal hematopoiesis, for our purposes, results in what are called the myeloproliferative neoplasms. Now, the myeloproliferative neoplasms include a number of diseases that are not the focus of the meeting today, and I'm just going to put those that are the focus of the meeting in a broader context. So we've mentioned ET, PV, and MF as three diseases that we're going to be talking about, and we'll see that these have a very important molecular signature. There's a molecule that's abnormal called the JAK2 molecule, which has a specific mutation associated with the majority of these patients. In the case of PV, nearly 100% of patients will have this molecular abnormality. So as you can imagine, this is the focus of a lot of our attention clinically and research-wise in these diseases. However, there is another myeloproliferative neoplasm called chronic myeloid leukemia. This is typified by a very, very specific molecular abnormality called the BCR-ABL translocation, which brings into juxtaposition two genes that are not normally found next to each other. This is a gene on the chromosome number 9. This is on the chromosome number 22. And that chromosomal translocation which occurs results in a chromosome called the Philadelphia chromosome. So chronic myeloid leukemia is Philadelphia positive. These are all Philadelphia negative myeloproliferative neoplasms, and I'll come back to that when we again look at how these diseases develop. Acute myeloid leukemia is yet another myeloid neoplasm. It can arise as a result of any one of these diseases up here, or it can arise de novo as a primary leukemia in itself. There's another form of a myeloproliferative neoplasm called myelodysplastic syndrome, which I'll show you on a later slide, and that really is the entire spectrum of myeloid neoplasms. We're going to be focusing in, during the next day or two, on these three diseases. So again, these are the diseases, PV, ET, primary myelofibrosis, and these are called Philadelphia negative classic or classical myeloproliferative neoplasms. I didn't mention, but there are other Philadelphia negative myeloproliferative neoplasms, and those are diseases that affect the eosinophils and the basophils, causing hypereosinophilic syndromes and mastocytosis. Those are also under the rubric of myeloproliferative neoplasms. So if we refer to Philadelphia negative, that means we're excluding CML. If we talk about the classic MPNs, it means we're excluding the eosinophilias and mastocytosis, and we're left with these three diseases which really take up the lion's share of our attention when it comes to MPNs. So let's have a look at what happens in the pathophysiological arena, in other words, abnormal physiology. Similar cartoon to what you saw before in terms of normal hematopoiesis, but there's some subtle but very important changes. Here we have a multipotent stem cell, we have our receptor, there's going to be a chemical which binds onto this receptor. The technical term for a chemical that binds to a receptor is a ligand, which means something that binds onto. However, in this case, we have some kind of genetic abnormality that occurs at the level of the multipotent stem cell. Myeloproliferative neoplasms are stem cell disorders. The abnormality occurs in the stem cell. And that will explain to us perhaps why all the MPNs may be associated with abnormalities in all the blood counts, the white blood count, the hemoglobin, and the platelet count, because they all derive from a stem cell, the abnormalities in the stem cell, and therefore potential arises for abnormalities in all the cell lines. So there's this acquired abnormality, and the abnormality refers over here to a genetic aberration. Something's wrong with the DNA. That may lead us off in the direction of a myelodysplastic syndrome, one of the myeloid neoplasms. We're not talking about myelodysplastic syndromes at this meeting, or a myeloproliferative disorder. And we now know the 4 myeloproliferative disorders that we mentioned before: chronic myeloid leukemia, PVET, primary MF. Any one of these diseases can progress to become acute leukemia or can develop into myelofibrosis. These stages of development over here, of progression of the disease, from one of the chronic myeloproliferative neoplasms to one of the more virulent, acute or not so acute conditions that complicate the classical MPNs, is also influenced by genetic aberrations that are found in addition to the initial genetic aberration that starts the whole process off. And that'll be the subject of the next few slides. Just to look at this story of signal transduction or signal transmission in the context of the JAK2 mutation, and we'll repeat this again for clarity, but this is really important. I think this is probably the most important piece of information to understand the molecular abnormalities in the MPNs in general. So in this cartoon, we have the cell membrane over here in orange. What's happening above that is outside of the cell. So you imagine cells floating around in plasma. So this is the plasma, the liquid part of the blood outside on top of the screen over here. Way down at the bottom, below these green bars, we have the nucleus of the cell with the DNA, with the chromosomes, with really the machinery, which is what's going to make the cell either proliferate and become more and more of itself, or differentiate into cells that are more mature, and can affect survival sometimes in the opposite direction, make the cells die. So we've got a message that's got to come in from outside of the cell and has got to influence something that happens in the nucleus. In between that, we have the membrane of the cell. We have this entire portion over here of the cell, which is between the membrane and the nucleus, called the cytoplasm, which is, again, the liquid part of the cell. But now we're inside the cell. We're beneath the membrane and outside of the nucleus. And this is where all the talking goes on. And there's a whole bunch of molecules over here that talk to each other and cross over here from different lines. Very, very complex, and tons, hundreds, thousands of people have earned PhDs just looking perhaps at one molecule and how it interacts with another and what influence that might have over there and how that influences back up there. Very complicated, not fully understood in any context, but in the context of myeloproliferative neoplasms, we have a fair working understanding of what's happening now. So under normal circumstances, there's a receptor over here, which I showed you before, and there's a ligand or a hormone. We can use a number of examples, as I will show you later on, but we could say that this is the receptor for erythropoietin, and the ligand is erythropoietin itself. That's the hormone that makes red blood cells. Now, once the ligand binds to the hormone, once the ligand binds to the receptor, that sets off a chain reaction, which we call signal transduction, which works via enzymes, one of which is JAK2, another one is STAT, of which there's a family of 5, and it activates them. It changes them from an inactive to an active state, and that, in turn, passes a message down. These messages are all chemical messages involved with phosphorylation, methylation, a variety of chemical reactions that, in turn, activate other genes to activate other proteins to send the message down until, finally, the nucleus gets the message, proliferate. And that is how we get proliferation of cells. So that is the ligand receptor signal transduction, signal cell proliferation chain of events. That is how it happens. That's normal. We will see that in the myeloproliferative neoplasms, the basic abnormality is that that entire system occurs autonomously. It occurs without the ligand because there is a mutation in JAK2, which is called an activating mutation. So this process of signal transduction occurs autonomously, not physiologically. You see over here, there is no ligand binding. There is just autonomous signal transduction. That is the core feature of myeloproliferative neoplasms. It's almost as though someone has pushed the start button and left it pushed in, and it doesn't come out automatically as it should after a certain period of time. That is the basis for myeloproliferation. It gets much more complicated than that, unfortunately. This is a pool of stem cells. Each stem cell here has a different color to indicate that they're different. That's normal. They're called polyclonal. If one of these stem cells develops a particular abnormality, the BCR-ABL, we have a very simple disease. BCR-ABL, which is the Philadelphia chromosome, causes chronic myeloid leukemia. One gene causes one disease, a beautiful model, easy to understand, and it happens to be completely true, which is why chronic myeloid leukemia is now a very successfully treated leukemia. In fact, it's curable. However, certain patients with chronic myeloid leukemia will be unfortunate enough to acquire a different mutation. One of the mutations that appears in the list on top here, which we'll refer to during the meeting, I'm sure, and that causes the stability of the proliferation to be lost, and this disease generates into acute myeloid leukemia. If we look at the example over here, where we have one particular stem cell, one of these blue ones, proliferating, making multiple copies of itself. This is monoclonal as opposed to polyclonal. These cells are identical copies of themselves. We have the beginning of proliferation. Now you notice here, we don't know what that is. We don't know what the gene is. It's not JAK2. Although JAK2 causes proliferation, JAK2 is not the initiating abnormality. We do not know what it is. We know that it happens early, but it doesn't happen right at the beginning, and I'll show you yet another slide to show that point. So that's how it starts. Then we have something which changes the phenotype. The phenotype means how the thing looks. So I have one phenotype, John has another phenotype, our faces are slightly different, we look different, we are phenotypically different, as we all are from one another in this room. Cells and diseases are also phenotypically similar, different, or identical. Chronic myeloid leukemia is phenotypically identical. I can see a blood smear of 5 different patients with CML or a bone marrow of 5 different patients with CML. I will not be able to tell you that they come from 5 different patients or they're samples from the same patient. But I can see a blood count and a blood smear and a bone marrow from 3 different MPN patients, and I'll be able to tell you these are not the same patient. That means that they have a different phenotype, not to mention the patients themselves, not so much their blood or their bone marrow, but the patients themselves will physically look different from one from another. However, I showed you on an earlier slide, and we'll mention it again, the vast majority of them have the JAK2 mutation, the identical mutation. So how is it that the identical mutation in different people causes diseases that look completely different from one another? Essential thrombocytosis and advanced myelofibrosis look nothing like each other, neither clinically nor laboratory-wise. The answer is there are disease-modifying or phenotype-modifying mutations that occur, and again, a number of them are listed on top here. And now we know it's not so much only the modification by mutations, but there are also other modifiers. There are epigenetic modifiers, things that happen to the DNA after there has been translation of the protein, things that occur in the surroundings of the cells, the stroma of the bone marrow, those surrounding cells, all have effects on the ultimate phenotype of the patient. So that is the explanation that we have as to how the same JAK2 mutation can give rise to patients that look completely different ultimately. So that's what we're showing over here. These phenotype changes lead you to have some blue cells and some blue cells that have red stars in them. And then again, there are these mutations, the same mutations possibly that occur in CML can occur in one of your stable conditions now, PV, ET, or MF, and transform that into AML of one or another type. So we have this transition over here from polyclonal to monoclonal to disease-modifying mutations to an aggressive form of the disease because they acquire a transformative mutation. Complicated. show you again, starting at the top. Something happens. Something happens. This is the initial event that happens in the stem cell. We do not know what that is. That causes the cell to become abnormal. At some point, the JAK mutation comes in. It's early on, but it's not quite as early as we had hoped or thought. In CML, the event would be up here. In the pluripotent stem cell, we have BCR-ABL. Simple. That's not the case for MPNs. There's another mutation called TET2, which happens very early. And now there's a question mark here. Does TET2 happen before JAK, or does JAK happen before TET2? The answer is both happen. After the slide was prepared by my friend Ayelu Teferi, a publication came out in the New England Journal of Medicine that showed that some patients acquire TET first and then JAK2. Other patients acquire JAK2 and then TET. So even here, we don't have any rules. And you know what? They look different. Patients who acquire JAK2 first and then TET look more like polycythemia vera. Patients that acquire TET2 and then JAK look more like ET. So the order in which the mutations occur is extremely important. So we have these mutations occurring early. Then we have the effect of the number of mutations that are present in a particular patient, something called the allele dose. Not all the JAK2 that we have is necessarily mutant. In essential thrombocytosis, in polycythemia vera, it almost is all mutated. And in myelofibrosis, only about half of the alleles that we have, or half of the copies of the gene, are mutated. If over time the number of copies that is mutated outweighs or outgrows, those cells outgrow the cells with a normal JAK2, then the disease will change. So we have patients that look like ET for months or for years, and all of a sudden the hematocrit starts increasing and they start to look like PV. We didn't really understand why that was happening until recently, when we know that that is to do with the number of alleles that have the JAK2 mutation in, as an example. Then there are other mutations, as I said before, that can interact and perhaps push a cell down towards myeloproliferative, primary myelofibrosis, other things that can make it go towards PV, where here the JAK2 allele dose is very important. And then there's another element which I haven't mentioned until now, and that is, what does the patient bring with him when he comes along to develop his disease? So-called germline mutations. The mutations that we've been speaking about until now in MPN are known as somatic mutations, from soma, meaning body. In other words, these are mutations that occur in the body rather than in the germline, rather than in our sperm and egg cells. Those are the germ cells, and mutations that we carry in our germ cells are really the mutations that are transferred in a hereditary manner, clearly. Sperm cells and egg cells is what we give to our descendants. The somatic mutations occur in different parts of our body. So somatic mutations in the eye can cause eye disease, and somatic mutations in the joints can cause joint disease, and somatic mutations in the stem cells can cause stem cell diseases like myeloproliferative neoplasms. However, even people that have somatic mutations that lead to MPN have germline, and they may have germline mutations. And it turns out that germline mutations may be important in the predilection that people have either to develop myeloproliferative neoplasms altogether, or if they do develop a myeloproliferative neoplasm, how will that develop into one of these three diseases? So we have a number of things over here that are in play that can influence what happens between this stage of pluripotent stem cell to the final product that we have here in terms of one of these three diseases. And as I've intimated, this might not necessarily be the end of the road, because sometimes we see people look like they have ET turning into PV, not so much vice versa, but certainly both of these can turn into myelofibrosis. So there's crosstalk and there's things that are happening. This is dynamic. I want to just summarize now some of the molecular details that we've been speaking about. JAK2 is very important, so we'll start with that. In myeloproliferative neoplasms, the JAK2 mutation is found in 95% of patients with polycythemia vera. The common JAK2 mutation is called the V617F mutation, which means that at one particular point, one of the bases of DNA has been switched for another. There is another JAK2 mutation, which is known as the exon 12 mutation. That's in a different part of the gene. And together, 95% and about another 2 or 3%, that accounts for about 98% of patients with polycythemia vera. It is almost true to say that anybody who does not have a JAK2 mutation does not have polycythemia vera. Almost true. There are exceptions, but they are very, very rare. And clinically, one would be very suspicious of making a diagnosis of polycythemia vera if we do not have the JAK2 mutation proven. However, in ET and MF, only 50 to 60% of patients have the JAK2 mutation. We'll see these numbers again. Another mutation, which was hinted to earlier, is called the MPL or the MAPL mutation. This is another one of those receptors that we have on our early stem cells. And the mutation in that particular gene occurs in about 5% of ET patients and about 5% of MF patients in both. It does not occur in polycythemia vera. So in ET and MF, we don't have a mutation in about 1/3 of the patients, or we didn't have a mutation in about 1/3 of the patients. The important mutations until now are the JAK2 and the MAPL, which is interesting but rare. This is MAPL. MAPL basically has the same effect as JAK2. Here we have the thrombopoietin hormone, similar to erythropoietin. This is thrombopoietin, and thrombopoietin stimulates the growth of thrombocytes or platelets. It binds to its receptor, which is called MAPL, and it activates again JAK2, and that would take us all the way down to the bottom of the slide into the nucleus. So it has the same effect as erythropoietin. And if there's an abnormality in the receptor over here, and there's two of these abnormalities are shown over here, we get the same effect as with the JAK2 mutation. We get autonomous signal transduction. This system works without having to have thrombopoietin in the environment to bind to it. So it's similar to the JAK2 mutation. And then about 4 or 5 years ago, the next breakthrough came, and that was the discovery of the calreticulin gene. Calreticulin is a protein that wasn't of much interest to hematologists previously, but the mutation was found to activate the JAK-STAT pathway. So in the same way that the mutation in JAK activates that pathway and allows for autonomous or independent cell proliferation, so too does the calreticulin mutation. And there are a number of these mutations which I will show you. So ultimately, these three mutations, the JAK2 mutation, the MAPL mutation, and the calreticulin mutation, have the same effect on the cell, and that is unregulated, independent, autonomous cell proliferation, cell division, accumulation of cells. And that's really the underpinning of the myeloproliferative neoplasms. These three mutations do occur early on in the disease. They're critical for the disease. They're extremely common. They actually drive myeloproliferative neoplasms, which is why they're now commonly known as driver mutations. So you'll hear that phrase used. The implication there is that this is what's driving, literally, this is what's driving the disease. You'll have noticed if you do a little bit of, I haven't told you the numbers yet, but you'll see that there are patients, rare patients, that have none of these mutations present. So there's something else going on over there, and we'll allude to that in one of the further slides. So these are the driver mutations. By corollary, the mutations that occur later on that transform the disease, that were on the top of one of the earlier slides, you'll hear about them, perhaps ASXL1, EZH, IDH. Those are mutations that come along later, once the driver is already driving. So unsurprisingly, those are referred to as passenger mutations. So here's a summary of the three mutations. This is the JAK2 gene. This is the way we denote the gene structure. We have over here the exon 12 mutation, which is rarer, and the very common V617F mutation in a particular part of the gene, part of the pseudokinase portion of the gene. This is the MAPL with its various mutations that are located over here, and then there's another few mutations located lower down in the gene. And this is the calreticulin gene, which you may hear a reference made to type 1 and type 2 mutations. This is a deletional mutation, which is called a type 1 mutation. This is an insertional mutation called a type 2. So there's type 1 calreticulin, type 2 calreticulin. They pretty much have the same effect on the cells. But interestingly, they are associated with different clinical features and even with a different prognostic outcome for patients. Summary of the driver mutations in myeloproliferative neoplasms. In terms of numbers, well, if we look at polycythemia vera, that's very easy. So we said, 97, 98% of patients will have the JAK2 mutation. The other mutations do not occur in polycythemia vera. So you either have JAK2 or you have none of the three big ones. In essential thrombocythemia, about 60% of patients will have JAK2, about 25% of patients will have calreticulin, about 5% of patients will have MAPL, 10% of patients will have neither JAK, MAPL, nor calreticulin. In other words, they're negative for three mutations, therefore we call them triple negative patients. Triple-negative patients account for about 10% of ET patients, and fortunately, we only have to remember that number once because they account for about 10% of primary myelofibrosis patients as well. The split of mutations is very, very similar between ET and PMF, and it doesn't help us distinguish between these two diseases, whether we do or do not have a particular mutation. So JAK2 is always in the majority, then comes calreticulin, then comes MAPL, about 5% in both diseases, and we're left with a group here, which is an important group of about 10% of patients who are triple negative, who have neither or none of the three driver mutations. These 10% are very interesting. Perhaps they actually do have a mutated clone that is too small to detect. Our level of detection now is getting better and better with a technique called next-generation sequencing. There could be other mutations that we haven't discovered yet. Perhaps there are more driver mutations that are very, very rare, and we'll have to wait for smart people to discover them. Or perhaps some of these patients do not really have a myeloproliferative neoplasm. Thrombocytosis, which is an elevation of the platelet count, is most commonly not caused by ET. It's most commonly caused by other disease processes, particularly malignancies and inflammatory conditions. So if a general practitioner sees 100 patients with thrombocytosis in his practice in a year, only one of them, maybe, will have an MPN. The other 99 will have an infection or a cancer or an inflammatory disease like Crohn's disease or ulcerative colitis. The last part of the physiology section deals with erythropoietin, and I'm going to take you through a series of slides over here that reinforces the idea of signal transduction and also will give a critical introduction to polycythemia vera. So, we need to understand about erythropoietin. Erythropoietin is a hormone. It has poiesis, which means growth effect, on erythro, which means red blood cells. If you break down the words with a little bit of basic Latin, it's always much easier to understand. This erythropoietin, interestingly, is made in the kidney. It's made in particular cells in the kidney, but it has its effects on the bone marrow. And it is stimulated by decreased partial pressure of oxygen in the blood. So when our oxygen levels decrease, a signal is sent, and we know how the signal works, but for today's purposes, we do not need to go into that. A signal is sent, a molecular signal, signal transduction, gene activation, occurs in the kidney as well, not only in the bone marrow. And the result of that is production of erythropoietin, and massive production. We can increase the erythropoietin production by tens of thousands of fold in response to hypoxia or decreased oxygen pressure. That has the effect of binding the erythropoietin receptor on one of those early precursor cells. This is not a pluripotent stem cell. This is a cell that's going to become a red blood cell, predestined to become a red blood cell. It expresses the erythropoietin receptor. Erythropoietin binds. That has the effect of making red blood cells. Once we've made our red blood cells, they carry oxygen. That increases the oxygen tension. So this arrow would flip up, and this signal would be switched off. Erythropoietin would not be produced. Red cell production would decrease, and we get back to a steady state. This happens in all of us all the time, every day, unless you have polycythemia vera. And the switching on and off occurs when there are rapid changes in oxygenation and also when there are chronic changes in oxygenation. So if people who live in Lima, Peru, which is, 6,000 feet above sea level, live under chronic hypoxic conditions, in them the system is turned on all the time. They have erythrocytosis, or a high number of red blood cells, which causes a condition called secondary polycythemia, as opposed to polycythemia vera, which is true polycythemia. The same goes for people who have chronic lung disease, heavy smokers, babies who have cyanotic congenital heart disease, which is basically a hole in the heart which doesn't allow blood to reach the lungs adequately. They live under chronic hypoxia, or chronic low oxygen conditions. They have very high hemoglobins. That's physiological. That's normal. That's compensatory mechanisms. So that is how erythropoietin and red blood cells are connected. Now let's just look at it one more time. Here's our erythropoietin receptor. Here's JAK2, which is an enzyme linked onto our erythropoietin receptor. If this is all we have, the system is off. Erythropoietin binds. The receptor changes its conformation. phosphorylation occurs at JAK2, cross-linking occurs between those two arms, and we get signal transduction. Normal. Red cells are produced. Polycythemia vera. Autophosphorylation, spontaneous phosphorylation, because of the abnormality in the JAK2, leads to signal transduction autonomously. No erythropoietin over here. We have no erythropoietin in this picture at all, but we have the same phosphorylation, which means activation of the JAK2 enzyme. And here we have multiple copies of red blood cells being made autonomously because of the mutation in JAK2. That was part one. Everyone still all right? Okay. Part two hopefully will be a little simpler to understand in terms of the structure of the talk. I'm going to now go through, as I said I would, the three Philadelphia negative, classic PMNs, and describe them as disease processes. Polycythemia vera. So polycythemia vera occurs in all populations. It seems to be less in Japan at least, and perhaps in the Far East in general. In general, the MPNs are diseases of older people. 60 years is the average age for patients with polycythemia vera. However, about a quarter of the patients are less than 50 years, and a good 10% are even less than 40 years of age. We do see this commonly in younger people. I use the word commonly liberally because these are rare diseases. Look at the incidence. Very, very hard number to pin down. But if you look at multiple references, you'll see that these diseases occur somewhere between 1 and 5 per 100,000 in the population, almost all of them. That's a ballpark figure. The particular reference I chose to bring you here mentioned about 2 or 2 point something per 100,000 individuals in the population. Hypertension, high blood pressure, 1 in 4. So primary care physicians, cancer, all cancers, 1 in 4. This is extremely, extremely rare. A challenge for primary care physicians to diagnose because they're not going to see many of them even if they spend 40 years in clinical practice. More men than women have polycythemia vera. So this is a disease of slightly older men. Clearly there are younger people as well. There is a familial tendency. The tendency is particular among Ashkenazi Jews, but there are other racial groups that have a higher incidence of polycythemia vera as well, and we do not know the cause. Some patients will report exposure to ionizing radiation or some other toxic material, but by and large, we do not know the cause of this disease in terms of an environmental cause. I mentioned perhaps germline mutations, and that really underlies this familial tendency. We certainly do see families where there are a number of the family members that have one or another of the MPNs. But again, to pin it down has been very difficult and has not been successfully done until to this date. Now we need to learn another group of concepts. This is a terrible slide, but it's there for your reference afterwards. It's terrible because you can't see really what's written over here. But this allows me to introduce you to a concept called the World Health Organization, or the WHO diagnostic criteria for MPNs in general. I'm not sure if you're familiar with this, but the WHO has advisory committees that really classify and define all of the hematologic malignancies, myeloid malignancies and lymphoid malignancies. We're clearly focused on the myeloid malignancies, and they do it disease by disease. And these have been adopted and published by a very important cancer network called the NCCN, the National Comprehensive Cancer Network, which is a network of about 20 or perhaps 25 medical centers in North America. I think there's some from Canada, but mainly the United States. And this is really our main guideline, our main source of information and recommendations for treating patients with hematological malignancies. The British have a very good set of recommendations as well, as do the Europeans. They mostly overlap, and in some areas they're actually identical. But I think that most people would look at the NCCN as their primary source of information. And the NCCN publishes the WHO criteria, and that is what they have adopted, and these are universally used. Now, these have been updated very recently, and we'll focus on the updated version. There's some very important changes that they decided to make compared to the previous version, which was 2008. In order to diagnose polycythemia vera, you have to have 3 of the major criteria, or 2 major criteria and the minor criterion. The first criteria is that you have to have a high hemoglobin. Now, how do you define a high hemoglobin? It's not as simple as it might sound. You've all seen blood counts, and there's usually a range between A and B, and if it's above B, then it's high. Well, who says what the numbers should be, A and B? What is a normal hemoglobin, 13 to 16 or 13.5 to 16.5? Firstly, the hemoglobin concentration varies. It varies according to age, it varies according to sex, and it varies geographically as well. And once more, it's the WHO that decides, or decided a number of years ago, what a normal or an average population's hemoglobin is. This is not a very high hemoglobin. In the previous set of WHO recommendations, the numbers here were much higher. They were 18.5 and 18. That led to us missing certain patients with what is called masked polycythemia vera. Patients who actually had polycythemia vera, but for one reason or another, the hemoglobin wasn't high, but they had the disease and they had the complications of the disease. So in order to capture these patients, they decreased the level at which we can start diagnosing polycythemia vera. The corollary of that is that we do a lot of investigating of people with a slightly elevated, or not even elevated, but just at the upper limit of normal hemoglobin, that end up not having polycythemia vera at all. But at least we're not missing patients with polycythemia vera. That translates into hematocrit, which you see over here, 49 and 48. The general relationship between hemoglobin and hematocrit is 1 to 3. So if you multiply the hemoglobin by 3, you should get the hematocrit in general. Or you can have an increased red cell mass, which is, I'll refer to it, which is a test which is done by injecting red cells which are labeled with an isotope, the radionuclide test, which is done very, very rarely throughout the world these days. No one likes working with radioactive material. So your first major criteria is a high hemoglobin. That seems to be kind of obvious with polycythemia vera. Your second major criteria is a bone marrow showing particular changes. I'm not going to go into all of them, but a good pathologist should say this bone marrow looks like polycythemia vera. In a word, all the 3 cell lines, the white cell line, the red cell line, and the platelets, in other words, the megakaryocytes, are all increased in number in a bone marrow biopsy in a patient with polycythemia vera. That's slightly different to what the bone marrow would look like in ET and MF, and we'll see that later on. And the third major criteria is the JAK2. I said JAK2 and PV have a 1-to-1 relationship, or almost 1-to-1 relationship. The minor criteria is a low level of serum erythropoietin. If you remember the physiology I just described to you, if I'm actively transmitting a signal through JAK2 and I'm making red blood cells, that will switch off erythropoietin. So because I have the JAK2 mutation, I have what's called erythropoietin-independent red blood cell production. And that feedback that I described turns off erythropoietin and it decreases the erythropoietin concentration in the plasma. So typically in polycythemia vera, we'll have a low erythropoietin level. We need 2 of these criteria, and hinted in here is the fact that you can actually diagnose polycythemia vera without having a high hemoglobin. How's that possible? Very simple. How about you have a patient with polycythemia vera who has an ulcer and they bleed from their ulcer? They're going to auto-correct their hemoglobin. They'll never have a high hemoglobin. We can also have a patient who has polycythemia vera whose bone marrow is not 100% typical, and we allow also for that very, very, very rare subgroup of patients in whom we do not find the JAK2 mutation. So those are the WHO criteria for diagnosing polycythemia vera, and we are very strict. You have to fulfill those criteria in order to have the diagnosis. What do the patients look like? Well, we said they tend to be perhaps middle-aged or a little bit beyond middle age, men more than women. That's not to say that the disease doesn't occur in women. Very often they will have neurological type symptoms, headache, visual disturbances, complaints of my head feels full, I feel like I've got a head full of cotton wool, I can't clear my head, very vague kinds of symptoms like that. Fatigue, lassitude, inability to function, itch, which is called pruritus. This occurs because there is also activation of that cell that I hinted at before called a mast cell. We mentioned mastocytosis. Mast cells are one of the granulocytes. They are one of the, it's actually a basophil. It's called a basophil in the blood, and in the tissue it's called a mast cell. So it also comes from that pluripotent stem cell, and therefore it's also affected in myeloproliferative neoplasms. But we don't see evidence of that because these cells are in the skin, so they're not cells that we measure in our blood tests. But there's activation of these mast cells, which is what causes the itch. and weight loss, which is a symptom that we'll be discussing at greater detail today in the session and in the afternoon session. Plethora is the opposite of pallor. Pallor means paleness, and plethora means ruddiness or redness. And these patients will often, but not always, have an enlarged spleen. There's really not much else that distinguishes them from anybody else, and very often the patients will feel fine and look fine, and the only way you can make the diagnosis is on the blood tests. So here's an example of a ruddy face. So when we get to the lab, what do we expect to find? As we've already mentioned, the hemoglobin and hematocrit will be elevated. If we do this red cell mass, which is a radioisotope study, we'll find that that's elevated as well. It's a stem cell disorder, so not unsurprisingly, there can be leukocytosis, elevated white cells, thrombocytosis, elevated platelets. In the blood chemistries, there may or may not be abnormalities in uric acid and an enzyme called lactate dehydrogenase, which is shortened to LDH. These are products of rapid cell turnover, and we often see these as elevated values in a serum chemistry. We've already discussed why the serum erythropoietin is low, because we lose the physiological feedback system, and the JAK2 mutation is a sine qua non. Just to show you a picture of a bone marrow, this is what a normal bone marrow looks like in an adult. These are fat globules, which is normal to find in bone marrow. You can see perhaps that there are different appearing cells over here, very low-powered picture, so you can't see the specific cells, but I think you can appreciate the difference in cellularity, in the amount of area that is covered by pink, which is really individual cells. These big cells over here that stick out are the megakaryocytes. Megakaryocytes are the cells that will become platelets. They're very, very large. The bone marrow often shows abnormalities of the chromosomes. There's some particular abnormalities that are typical for polycythemia vera, and these abnormalities are becoming more and more important as well. They're extremely important in myelofibrosis, which we'll discuss, but they're becoming important in polycythemia vera as well, at least in understanding the disease. How do we go about diagnosing? It's become very simple. We start off with two simple blood tests, one prick of a vein, and we can know if you have the JAK2 mutation or not, and we can know what your serum erythropoietin level is. And it looks something like this. If you have the mutation and your erythropoietin is low, you have polycythemia vera and you do not need to carry on and do a bone marrow biopsy. You can almost say that with certainty. If you also have the high hemoglobin, well, then you have the diagnostic criteria that you need according to the WHO. On the right over here, if you do not have the JAK2 mutation and your erythropoietin is normal or high, then you almost certainly do not have polycythemia vera. You have one of those other things that I said before. You have a heart disease, lung disease, a heavy smoker, and so forth, which is causing secondary polycythemia. A problematic group sit in the middle over here. They have the mutation, but their erythropoietin is normal, or they don't have the mutation and their erythropoietin is low. These are the people that will have a bone marrow, and then we'll have another criteria to diagnose the polycythemia vera with, or not. So the diagnostic process actually starts off with something that's extremely simple. It's available, I think, in most parts of the world on a routine basis. Moving on to treatment. There are two key elements in the treatment of polycythemia vera. We need to control the hematocrit. In many countries in the world, we refer to hemoglobin. In North America, hematocrit is used instead of hemoglobin routinely. However, when it comes to polycythemia vera, the whole world talks about hematocrit. And remember, the relationship between hemoglobin and hematocrit is usually 1:3. It changes with certain treatments, but as a general rule, 1:3. So we want the hemoglobin, or the hematocrit rather, to be less than 45%. This is as a result of a particular study that was performed a number of years ago. There are some patients that will benefit from a hematocrit that's even slightly lower. In the old days, we used to differentiate between men and women, and we had a different standard for men and women. Now, men and women are both controlled at a level of below 45. Some people think that perhaps women should go down even further because women normally have a lower hemoglobin than men. How do we do this? We've got a number of options now. Phlebotomy, which is simple bloodletting. It's similar to donating a unit of blood. It's anywhere between 200 and 400 milliliters of blood that will be removed. That is the standard treatment for younger patients, by definition less than 60 years of age, whereas some kind of drug treatment, and the first drug to be used would be hydroxyurea, which is a form of chemotherapy, which means that it impairs cell replication. That's what we would use preferentially in patients who are above the age of 60 years, and I'll explain why in a moment. Second-line therapies would be interferon, which we would sometimes use preferentially, for example, in a younger patient, a young woman. That's not the typical person with PV, but we certainly do have young women who want to be pregnant, and they can only receive interferon. They cannot receive hydroxyurea. A new drug on the market for polycythemia vera that's licensed in North America and in Europe is ruxolitinib, which is Jakafi. We'll refer to that again when we talk about myelofibrosis. And this is used for resistant disease, patients that have not responded to hydroxyurea. So we have options here as to how to control the hematocrit. What's important, bottom line, is that the hematocrit is controlled. Second arm of treatment is interfering with platelet function. And the classic drug that we have that interferes with platelet function is aspirin, given at a dose of somewhere between 75 and 100 milligrams. The commonest dose used is 100 milligrams. How do we decide who to treat how? So we have what's called a risk-adapted strategy, and you will see it for the following diseases as well. And we divide the patients conveniently here into two groups, low risk and high risk. And the things that define low risk are age and a history of thrombosis. We'll come to it, but one of the main complications, if not the main complication, during the lifespan of a person with polycythemia vera is the development of a thrombosis, of a blood clot. And the blood clots can be in a variety of anatomical locations, which I will show you. If a patient with polycythemia vera has had a blood clot as a result of his polycythemia vera, he by definition is a high-risk patient, high risk for a blood clot in the future. If a patient is above the age of 60 years old, he by definition is at high risk for a blood clot. So we have two defining factors for high risk for blood clots in polycythemia vera. We do not consider the risk of transforming to leukemia or the risk of transforming to myelofibrosis when we do our risk-adapted strategy. So risk over here equals risk for thrombosis. So if we have a young patient who's never had a thrombosis, he will have his aspirin and his bloodletting. I'm not going to get into what happens if you have a very high platelet count. That's a subgroup of patients. Perhaps we can talk about that in the questions and answer session. But if we have a high-risk patient, that means you're above 60 years old and or you've had a thrombosis. You may get phlebotomy in order to help us get your hematocrit down, but you will need hydroxyurea as well. Studies have shown that if you look in these high-risk patients and you treat them either with phlebotomy or with hydroxyurea, you will see more recurrent thrombosis, more recurrent blood clots with the phlebotomy group. So in some way, which we'll talk about, hydroxyurea has an additive protective effect compared to phlebotomy. It probably is because hydroxyurea also decreases the platelet and white cell counts as well. When we phlebotomize patients, we decrease their hemoglobin, we do nothing to their platelets or their white count. When we give hydroxyurea, since it's chemotherapy that acts on the stem cells, it decreases all of the platelets, white cell and red cell numbers. And then if we have these high-risk patients who cannot tolerate hydroxyurea for reasons that I'll discuss, we can then go on to these other drugs that I mentioned. Interferon, busulfan is a form of chemotherapy that's given to older patients sometimes, and then we now have ruxolitinib or Jakafi as well. Polycythemia vera is a fascinating disease, as are all the MPNs. And these patients can undergo a variety of changes in their disease which make them look different. They have a different phenotype. So there's early stage, which happens initially, and sometimes there isn't even polycythemia over here, and these patients are what we call masked polycythemia vera. Very important to diagnose them, because if they're not diagnosed, they're not treated, and if they're not treated, they suffer all the consequences of polycythemia vera. So we're quite active about trying to diagnose these patients early, even if they don't really look like polycythemia vera. Then the disease manifests with the plethora and the itch and the weight loss and the lassitude and so forth. And this will carry on for years, decades. During this time, the spleen will grow, fibrosis may develop in the bone marrow, and at some point the patient may transform to post-polycythemic myelofibrosis. It occurs in about 30% of patients after decades. And in a smaller percent of patients, probably less than this number, perhaps up to 10%, there will be another gene abnormality that creeps in over here, one of those transforming gene abnormalities, and this will end up as an acute myeloid leukemia, which needs to be treated very aggressively, including with bone marrow transplantation. So the disease evolves, and the patients don't look the same today as they looked 10 years ago. The same patient over a 10-year period will look completely different, and this afternoon I hope to share one such patient with you. So this is what happens, as I mentioned. Here I've put 5%, which I think is perhaps a more realistic number of patients that will have a leukemic transformation. About 10% will develop post-polycythemia myelofibrosis. Again, these are very, very late events, and we don't actually focus on these at all during patient management during their early years. What do we focus on? Thrombosis, because 40% of patients with polycythemia vera, if not treated appropriately, will develop a thrombosis, and a smaller number of them will develop bleeding as well. Patients with polycythemia vera have a reduced overall survival compared to age and sex-matched healthy populations, but their overall survival is very long. This is an example of a blood clot taken from the leg of one of my patients. Unfortunately, this is a post-mortem finding, and this resulted in a blood clot in the lung as well, which is what the patient succumbed from. And so this is what we're trying to avoid. This is an extreme example, but this is what a blood clot looks like if it develops in one of your veins. This is perhaps a bit more schematic. This is what a leg looks like if it has a clot in, as you saw in the previous picture. This is a deep vein thrombosis. A deep vein thrombosis forms in the veins, usually of the lower leg. A little bit can break off and embolize or flow towards the lungs. The veins of the body lead to the right side of the heart. The right side of the heart pumps blood into the lungs, and that's where this clot will lodge, where the pulmonary embolus will lodge. So a clot in the vein, most patients are afraid that it's going to end up in their brain, but it isn't. It's going to end up in their lung. Clots that come out of the left side of the heart, those are the ones that end up in the brain and can cause a stroke. But typically over here, the clots cause pulmonary embolus, which is also a very serious condition and can be fatal. So these are two examples, very common examples of clots developing in veins. There's another group of veins that in the myeloproliferatives are very, very commonly affected, and these are called splanchnic veins or abdominal veins. The very big ones are the portal vein and the splenic vein, that big venous system that links the spleen, shown over here in purple, and the liver, shown over here in brown. And these veins are particularly susceptible to clot formation in MPNs in general. The veins in the liver, called the hepatic veins, are very susceptible to clot formation, particularly in polycythemia vera, leading to a syndrome called the Budd-Chiari syndrome. And veins around the organs of the abdomen, such as the stomach and the small intestine, called the mesenteric veins, are also susceptible to blood clot formation in myeloproliferative neoplasms, to such an extent that if such a patient appears in the hospital or in the clinic, and they'll usually appear in a surgical department because the main complaint is severe abdominal pain, and that is the diagnosis, splanchnic vein thrombosis. Even the surgeons know today that they need to be looking for the JAK2 mutation, or at least they need to be looking for their local hematologist to try and explain why this has occurred. Other thromboses or blood clots that can occur in the arteries, and when blood clots occur in arteries, they typically cause stroke or myocardial infarction or heart attack. Essential thrombocytosis may be known also as essential thrombocythemia, but we'll just call it ET. We have the NCCN guidelines again. Here, we need all four major criteria, or the first three and a minor one. No one remembers these off by heart. I have them pinned up on my wall just to make sure I don't forget them. We're talking about thrombocytosis, high platelet count, so you need a high platelet count. That's fairly obvious. The bone marrow looks different. I'm not going to go into the details, but a pathologist can tell you this bone marrow comes from PV, this bone marrow comes from ET, or this bone marrow is normal, just very proliferative because it's a patient with Crohn's disease, which is a chronic inflammatory disease. You need to exclude some other things over here because having a high platelet count is very, very common. And in fact, myelodysplastic syndrome, chronic myeloid leukemia, other diseases can cause a high platelet count. So your work's a bit more cut out for you over here if your patient presents with a high platelet count rather than with a high hemoglobin. You need one of these three. It's not only JAK2 anymore. That's the case in polycythemia vera. If you remember, that was an exclusive mutation in polycythemia vera. Here we have all the three driver mutations that you need to test for. And again, all the three of these are readily available now for routine clinical testing in most parts. And then your minor criteria is what I've hinted at until now. You need to make sure that you do not have reactive thrombocytosis. So if you have a patient with Crohn's disease or a younger patient with iron deficiency, which is another cause of a high platelet count, you have to think very carefully whether your patient really has ET or they have perhaps reactive thrombocytosis. This is a blood smear. These are platelets, these tiny little cells. These are red cells, and these are white cells. This is a blood smear of a patient with essential thrombocytosis. So all of these are the platelets, and you can appreciate over here the huge number of platelets that are present in this patient's blood smear compared to the normal, which is what you see on the left. The bone marrow showing megakaryocytes. The epidemiology. Again, all populations. Mean age is slightly lower, 55 rather than 60. And here, the women beat out on the men. The same incidence, 2 to 3 per 100,000 rare diseases. What do the patients look like? Well, they very often have what we call microcirculatory features. So perhaps obstruction, sludging of blood flow in the small blood vessels, and this particularly will lead to a very specific syndrome called erythromelalgia, which is very painful red extremities. I'll show you a picture of that. And that almost only happens with essential thrombocythemia. Again, you have the neurological symptoms, headaches, paresthesia means funny feelings, tinglings in the limbs, visual and hearing loss, TIA, which is a minor stroke, a transient ischemic attack. Think of the general practitioner seeing someone with a headache who's not feeling well, they're not going to think of essential thrombocytosis first off. They're going to think of high blood pressure, diabetes, any one of the common diseases that can cause the similar kinds of sensations. These patients, again, suffer from thrombosis, just like the PV patients. And here we have this paradoxical finding of when the platelet count is very, very high, more than one, certainly more than 1.5 million platelets, where normal would be up to about 450, we get this paradoxical bleeding phenomenon, which is very important to acknowledge. These are pictures of some of my patients. All these pictures were taken with patient's permission and permission to display the patient's pictures as well, by the way. That goes for all of my pictures. This is a patient with a deep vein thrombosis with essential thrombocytosis of their leg. Look at the size of that leg compared to the size of that leg. Here we have a superficial thrombosis that you can see just under the skin. This is erythromelalgia. I think you can appreciate the purple discoloration, the swelling of the toes that you can see over here. This was a patient who had 2 million platelets and needed emergency platelet pheresis. 5 minutes. Some hemorrhages. Laboratory abnormalities, elevated platelet count, elevated white count, hemoglobin will typically be normal, the mutations. How do we treat these patients? Risk adapted, we want to prevent clotting. Same risks as before. Low risk, you're young and you've never had a thrombosis. High risk, you're either old or have had a thrombosis. Other factors that we're starting to account for over here, which now makes our risk adaptation much more complicated. You may hear about the IPSET, which is International Prognostic Scoring for Essential Thrombocytosis. This is the revised score, which now allows us in a very sophisticated way to define 4 different groups. And that's very helpful because that allows us to treat the patients. So some patients will not be treated at all. Those that don't have the JAK2 mutation, remember that's about 50% of the patients, who are young, who don't have cardiovascular risk factors, they're not obese, they don't smoke, they don't have a family history of heart attack, will do nothing, and they're going to live forever. Others will get aspirin, and the high-risk patients who are older than 60 or have had a thrombosis will get the aspirin, and they'll get the hydroxyurea or another one of the drugs that decreases the platelet count. What happens to these patients? They get a thrombosis, less so than in PV, but they do. They bleed. They may develop myelofibrosis or acute leukemia, but much less so than polycythemia vera. Essential thrombocytosis patients live just as long as anyone else in the population. Finally, myelofibrosis. Again, this is a disease of the bone marrow. Ultimately, it leads to bone marrow failure, which is characterized by pancytopenia, which is a decrease in the blood counts. The symptoms here are really what distinguish myelofibrosis from the other myeloproliferative neoplasms, and they're either generalized or related to the spleen, which is typically very enlarged in these patients. And these patients also have a phenomenon called extramedullary hematopoiesis, which means making blood outside of the bone marrow. The medulla is the bone marrow, so they make blood outside of the bone marrow, and I'll show you that. Blood film can be typical with abnormal forms of red blood cells because of the fibrosis of the bone marrow. And in the peripheral blood, you also see these precursor cells. These are cells that should only be in the bone marrow and should not be in the peripheral blood, and here they appear. The bone marrow morphology, again, is very abnormal and should be recognizable by a pathologist. All populations, older people, 65, we do not know what causes this, and again, 1 in 100,000. The WHO gives us the criteria, which we're not going to belabor because they're long and there are a lot of them, but what's important over here is to realize that in 2016, we have a new category, which is pre-primary myelofibrosis, or early primary myelofibrosis, a very important category. These patients until now were misdiagnosed as ET. They look like ET. They do not look like PV. They do not look like MF. They look like ET. They have thrombocytosis. But if you look very carefully, particularly at their bone marrow, you'll see that they have an early form of myelofibrosis, and they end up acting like the overt or the full-blown myelofibrosis that we know, and they need to be treated as such. The clinical features, as I said, are very much related to inflammation and proliferation. Ineffective erythropoiesis leads to anemia. The spleen is large. Catabolic symptoms, weight loss, itch, cachexia, which means severe weight loss. This is a patient of mine who has extramedullary hematopoiesis. These are tumors which, when we biopsy them, show bone marrow. Bone marrow cells exist outside of the bone marrow as well, particularly in the liver and spleen. And when the marrow is switched off because of fibrosis, other parts of the body start making blood cells. These tumors are unsightly, they're not painful, and this patient elected not to have them treated. The ideal treatment for this would be irradiation. Blood count abnormalities are variable. The blood counts can be high. As I intimated, usually at the end of the disease, the blood counts are all low. We have the typical chemistry abnormalities. We have chromosomal abnormalities. We have a variety of mutations. Just to remind you, we have this 10% of patients who are negative for any of the 3 mutations. The bone marrow looks abnormal with fibrosis, abnormal megakaryocytes. We diagnose it by looking at the blood picture, having splenomegaly. We very often can't aspirate or withdraw liquid bone marrow. And when we withdraw the solid bone marrow, we see the fibrosis. We have no other cause for fibrosis, and we have the molecular abnormality in almost 90% of patients. These patients have a worse overall survival. This is 100% of patients alive. This is 0% of patients alive. So you can see over here that the patients tend to fall off this curve and unfortunately die. How can we tell who's going to do better, who's going to do worse? We have a number of predictive scores called the IPSS, the DIPS, and now the DIPS Plus, where we take into consideration 8 factors, and that allows us to separate out people who will have a very good overall survival. They live for up to 20 years, and people have very poor overall survival. They live for less than 2 years. Clearly, these people we have to do very little for. These people we have to do a lot for, and quickly, if we want to try and change the trajectory of their disease. We can do the same thing now with these marker molecules, and look at the triple negatives. They don't have any of those 3 mutations, but look how badly they do. They die quickest of all. So it's important now to identify them early so we can intervene, hopefully while most of the patients are still alive over here, and say, look, your future doesn't look good. We've got to do something to push you back up onto one of these high curves so you can live for a long time. We should try and cure myelofibrosis in the more advanced stages, and the only way we can do that is by doing an allogeneic stem cell transplantation, which means taking cells from a donor. We try prolonged survival. We have a drug that perhaps can do that, but we mainly deal with symptoms. Again, we have a risk-adapted approach, so the higher risk you are, the more aggressive the treatment will be. Patients that have low risk and are asymptomatic, we do nothing. Patients that are at high risk, we take them all the way to a transplant, sometimes immediately and sometimes very, very soon. My last slide, I just want to spend a minute on the symptoms, because this is, I think, very, very important. I've divided the symptoms here into 3 different symptom groups, and we'll be speaking about them later on this afternoon. What are called constitutional symptoms, that is weight loss, lassitude, fever, itch, all of those very nondescript general kinds of symptoms which are totally debilitating. We have a good drug now called ruxolitinib or Jakafi, which can deal with these symptoms, and we often use steroids as well. Splenomegaly, the spleen can be huge. You saw a picture of a very big spleen in one of the earlier slides. Ruxolitinib, Jakafi, can reduce the size of the spleen in a good number of patients, almost half of the patients significantly reduce. We sometimes have to resort to chemotherapy for that. Very, very, very infrequently we'll do a splenectomy, which means removing the spleen surgically, and we almost never now do irradiation of the spleen, which works poorly and for a short period of time. The third group of symptoms relates to anemia, and the treatment for that would be injections of erythropoietin. It only works in a small minority of patients. Androgens, which are male hormones, which work to some extent. Thalidomide is a particular drug which works together with corticosteroids, but the majority of these patients with anemia, not the majority, but almost half of the patients with anemia will end up getting chronic blood transfusions, which unfortunately is not good for their quality of life and leads to other symptoms as well. I just want to acknowledge people that I work with back at home, part of our MPN working group, and some of the people that I work with in my hospital. Thank you.
Thank you very much indeed, Martin. That was a really excellent overview of MPNs. My doctor is going to be joining us later in the meeting, Claire Harrison, who many of you all know. Don't tell Claire, but I've been watching presentations on MPNs for the last 18 years. I actually learnt quite a few things this morning, so thank you very much, Martin.
Thank you.
We have about 10 minutes or so for questions. If it takes a little bit longer than that, that's okay, but lunch does start at 12:30. So who would like to ask a question? If you would, please press your button on your microphone and your microphone will be live.
Yeah, thank you. My name is Peter. I'm coming back. You say that the PV patients have a life expectancy of 10 to 20 years. I must be very lucky because I have it since 22 years, at least diagnosed since 22 years. At that time, they told me you have about 7 to 8 years to live. So we're improving. It's good. I think the biggest problem which we have is that we don't really know since when do we have a PV. Because, normally you're just being diagnosed because you made a blood test. Okay, you have certain symptoms, but I had, for example, erythropoietin since, without knowing it, since I was 30 years old, but I took an aspirin and that settled the whole problem. So how do we come to such a figure? Which basis are you taking to come to it? I think it's always frightening for a PV patient to hear these things.
Thank you very much for that question, and it's something that I wrestle with daily. I'd like to answer it in a few parts. Firstly, factually. When we talk about overall survival, it's obviously based on literature, experience in the literature. A fortune of this literature comes from the Mayo Clinic, because the Mayo Clinic has a strong history of data collection in myeloproliferative neoplasms because of one particular individual whose name was Murray Silverstein, which may be a name that some of you heard. I hope he's still alive, but if he is, he hasn't been in practice for many years. He developed a huge database of thousands of patients that were seen at the Mayo Clinic. Some of these patients actually lived in Rochester, Minnesota, and they have data on them going all the way back to their birth. However, a lot of them were seen as consultations that came from all over the world to see Dr. Silverstein, who was then considered one of the giants in polycythemia vera in particular, and MPNs. So they, I think, probably have got the longest history and the biggest database regarding MPN patients in general and PV in particular. The definition of disease duration is from the time of diagnosis. So if someone is diagnosed today and they say, well, you've got 5 years to live with this disease, well, maybe I developed the disease 4 years and 300 days ago, and I've got 10 days to live. Clearly, that's not the case. So the case is from the time that you were diagnosed. That's the first point. That's a technical answer to your question. I think the more important answer to your question is that these are what's called a median. These are median survivals. That means that is the number of years that most of the patients will live for. But statistically, that means that there'll be a lot of patients that will live a lot longer than that, and there'll be a lot of patients that will live less than that. Therefore, when I see a patient, to be perfectly frank, I don't enter into that discussion at all. And I sort of hinted at that. My job is to prevent them from having a thrombosis. That is the main order of the day. In myelofibrosis, you've got to treat symptoms. Myelofibrosis patients have a very low incidence of thrombosis, much lower than PV and ET. So sort of think conceptually. PV and to some extent ET, your job is don't let the patient have a thrombosis and make them feel good. And again, the patient that I'll present in this afternoon session, I think, will show those two elements. We don't want patients walking around out of thrombosis but feeling terrible because they've got erythromelalgia or pruritus or weight loss. So we've got to look at both things. So it's the here and now. What's going to happen in the future at this point is not determined by anything that the doctor does or doesn't do today, and B, not entirely predictable. I'd like to expand on those two statements. Can anything that I do today either increase or decrease the risk of someone developing leukemia or myelofibrosis if they have PV or ET? There's only one thing that I can do to make the person's condition worse, possibly, and that is give them a bad drug that will increase the DNA damage in their bone marrow cells. The biggest problem that we have with that is with hydroxyurea. Hydroxyurea gets, every couple of years, bad press, where an article will come out saying, we looked at a population of patients, and instead of 4% transforming to leukemia, 7% transformed to leukemia. Does that mean that hydroxyurea causes leukemia in polycythemia vera patients? The true answer is we don't know. We're concerned about it. And therefore, we typically will not use hydroxyurea in younger patients. I'm not sure if anybody ever here that wants to define younger. I'm not going to put myself at risk. But a ballpark figure is 50. Some people will not use hydroxyurea before 50. Some people definitely won't use it before 40. And some people insist that hydroxyurea does not cause leukemia. It is not a leukemogenic drug. There are other forms of chemotherapy that we avoid like the plague, one of which is busulfan. Radioactive phosphorus you can't even get anymore. Those cause leukemia, no question. We don't know of any drugs that can cause myelofibrosis. So the two very long-term serious complications of PV, and to a lesser extent ET, are unavoidable. Unless you want to consider hydroxyurea, which I'm not going to debate now. That depends on you and your patient. In terms of trying to predict and tell the patient, look, you're at risk for developing acute leukemia or myelofibrosis, and your survival is predicted to be earlier or less than someone else's, for that we need the proper molecular markers. And we're only now just starting to get into that, again with the Mayo Clinic group, buttressed by the group in Florence, who have hundreds of these patients, who are now molecularly characterized, the same way that we did for myelofibrosis. They did for myelofibrosis. They're also now doing for polycythemia vera. And this is actually groundbreaking, and it's quite revolutionary, because polycythemia vera was a disease where you had a high hematocrit, you did a phlebotomy, and you gave aspirin, and you went home. Now it turns out that the chromosomal abnormalities and the genetic abnormalities, all those passenger mutations, they're all there. We just didn't bother to look for them. A lot of them we only discovered recently, but they're there just like they're there in the PV patients. So the last few slides that I went over quickly with those curves that separate, that's for myelofibrosis. We're there. We're almost there now for polycythemia vera. And I hope if you ask me to give this talk in a couple of years' time, I'll be able to, and I'll have to show you curves of PV and say now the WHO criteria for PV are do all of this and do the passenger mutations. If you've got such and such a passenger mutation, don't only do phlebotomy, use this drug or that drug. So that's the long answer to your question. The long answer is we need better predictors, which we don't have at the moment. Therefore, I think that the practical thing is to explain to your patient what kind of disease they have, explain to them that this is what may happen in the immediate future and this is what we need to focus on, and what happens in the distant future is something that is, in my mind, not valuable to raise in discussion. To be perfectly frank, certainly in the first or second consultation, I don't necessarily raise it, but clearly patients ask these questions, and then they get the kind of answer that I've just tried to give you now. Hopefully not so long-winded.
Okay, thank you very much. Do you
Dave,
think that
a
genetical test is valuable? I'm doing that every 2 years.
A genetic test?
Yeah.
For other mutations?
To see whether the mutation of VIAC is the same or has changed or whatever it is.
The allele burden?
Yeah.
Yeah. That's something that's being looked at in research settings, and it's not really meant to be done in clinical practice because I'm not sure how we would react to a change in the allele burden. So it's of interest only, but not of practical import.
Dave, you have a question?
Yes. So we hear of some research reports that after X number of years, ruxolitinib can stop working in MF patients at some point. Does that also occur in PV? And if so, is it longer years, or do we not have enough data yet to determine that?
The last. We don't have enough data. The PV studies are fresh. The one's just been published. The other one is still ongoing, with and without splenomegaly. I do not recall offhand the dropout rate of patients, but it was a dropout rate that was related to intolerance rather than progression, as I recall. Claire will certainly have all that information at her fingertips. But we can't compare the two diseases because the follow-up time for PV is much, much shorter than for MF. My suspicion is that that'll happen as well. I think that especially if the ruxolitinib in PV is being used for symptom control or for spleen control, it will probably wear itself out, and there'll be a resistance that develops to it. If that'll happen in terms of hematocrit control or not, I'm not sure. I don't think anybody knows, to be frank.
Okay, thanks.
Cheryl.
Yes. I have a question with regards to, has there ever been any research done to when the average age of a patient when the mutation occurs? Are they born with the mutation? And if so, when does that activate? We're seeing a lot more younger patients. You talked about this being an old person's disease, and we're now seeing folks less than 40 years old. So has there been any research done as to if this mutation, that the people are born with it, and then when does it activate? People are asking, patients are asking these questions.
Right. I'm not aware of any published research in that regard. I wouldn't be surprised if people are doing that kind of thing. I know that there is data on, is there a population of healthy people that have the JAK2 mutation? And the answer is absolutely yes, but that's a feature of aging. It's become a very big area of research in myeloid neoplasms. A lot of these mutations, particularly the TET2 mutation, but the JAK2 as well, are found in as many as 5 to 10% of people over the age of 75 or so, 70, 75. So that's the opposite of what you're asking me. I'm not aware of any screening of children, for example, to find these mutations. I think that it's generally accepted that you're not born with a mutation, but I don't think that anyone's really looked at it to that extent. Again, the question is, it would be interesting, but what would you do about it? Because as you said, something's happening to activate the mutation, so to speak, or perhaps a bit more precisely put, another mutation is occurring or another event is occurring. This is not the driver mutation. This is not occurring in the pluripotent stem cell. So you might be sitting around with a population of more mature cells that have a JAK2 mutation and nothing's happened, like a sleeper agent, if you want to use a spy novel sort of analogy, until the agent gets activated by something else. What is that something else? Could we avoid that? That will beg the question. If you know that 0.1% of 15-year-olds have a JAK2 mutation, practically I'm not sure what you do about it. The short answer again is that we don't know when these mutations actually occur. And somebody might be looking at it, but I haven't seen anything published on that.
Over here. Yeah.
Hi, I'm Sharon from Australia, and I think I was a younger patient when diagnosed because I was 18, diagnosed with PV and MF. So I've had that it's progressed to MF now. So ET, PV, progressed to MF, so 26 years. Where do you see new cures? Like, where do you see that? Is it in immunotherapy? Is it in gene editing? Is it in new drugs that may reverse fibrosis for MF? Where should research now be targeted to find cures that are not as bad as having a stem cell transplant?
If I'm not mistaken, there's a session that's going to deal with that extensively, and there will definitely be people here, certainly Claire Harrison and others, who are much better equipped to answer that question than I am. But I think that your question is the right question, and it's a question that we as researchers, clinicians, should all be asking ourselves and each other all the time. I'll just tell you about two directions that I'm aware of now that are being developed, and you'll hear a lot more about this. So there are drugs that can reverse fibrosis. This is a completely new area for us. These drugs have been developed and are being developed for other conditions that have fibrosis as part of their disease. So chronic fibrotic lung diseases, a very bad disease called retroperitoneal fibrosis. There are drugs that make use of the fact that you can shift the direction that cells develop in from fibroblasts, which are the cells that make the fibrosis, back to something called monocytes, which is where they came from in the first place. And there's a drug called pentraxin, which is in clinical trials at the moment to see whether you can actually reverse the fibrosis which already exists. The overall excitement level about that is not very high at the moment, unfortunately. Another brand new area which is being investigated in myelofibrosis is looking at the length of the chromosomes. Chromosomes have a cap at the end of them called a telomere, and the telomeres in all of us shorten each time a cell divides. Remember at the beginning we spoke about that mitosis, the cell division, and when your telomere gets too short, then the cell dies and you don't have a cell that divides anymore. One of the problems in a lot of cancers is that these telomeres never get shortened. There's an enzyme called telomerase which keeps on lengthening the telomeres, so the cells live forever and they keep on dividing and dividing and dividing and dividing. And that was thought to be a nice target for MPN, and a drug was studied in other cancers called imetelstat, and was found to be not useful in other cancers, but happened to be very useful in myeloproliferative cell lines, and it was studied and published in Essential Thrombocytosis. So it was very useful in essential thrombocytosis, and it's now in clinical trials for myelofibrosis. So again, that's another completely different tack which one can take to try and deal with myelofibrosis. Is that going to be a blockbuster? Probably not. Is it going to reach the market? I have no idea. Other drugs that are in development work along the lines of the JAK inhibition. You may know that ruxolitinib is a JAK inhibitor, not a JAK2 inhibitor, and it's not a JAK2 mutant inhibitor. It's just a general JAK inhibitor. So now they're developing drugs that will specifically target the JAK2 mutation, that V617F that I showed you before, and that might be something that's much more effective and useful than just targeting JAK altogether. There is some initial talk now about immune therapy. In actual fact, we've had immune therapy in myeloproliferative neoplasms for a long time, but it hasn't really been called that, and that's treatment with interferon. There are people, very serious clinicians and researchers, that are convinced that the best drug that we have for MPNs is interferon. That's a drug that makes the most difference to the biology of the disease. And interferon is an immune modulating drug. It has multiple effects on multiple different cells in the body. It's also used for a variety of different diseases, including viral infections, hepatitis C. So that's an immune modulating drug. So because that drug apparently is very effective, it is very effective in myeloproliferative neoplasms, there is probability that other immune modulating drugs would have effect as well. If we could only find a molecule that's expressed on the surface of the myeloproliferative neoplasm cells, we could make an antibody to target that molecule in the same way that there are antibodies that target leukemic cells and lymphoma cells that our colleagues deal with, and that would be sort of a pathway into immune-type therapy. That's not the case at the moment. As far as gene editing and CRISPR technology, again, you'd have to know what gene you want to edit and which gene you want to modulate, and I think that it's very, very important to really try and understand these diseases before trying to treat them. I'm not sure if anybody could even pick a target to modulate at this point with a technique like gene editing. There are a variety of other drugs that are in development, and what often happens is that when you've got a few drugs that are active, the next sort of stage in clinical research is to combine them. So there's a lot of combination therapy drugs, combination of drugs that are being tested as well in clinical trials.
Can I ask one more question?
Go ahead.
It's a simple one. I was told that my MF is a cellular MF. Can you explain the difference between fibrotic MF, cellular MF?
Yes, now I can, very simply, because the WHO has given us a category called early PMF, or pre-fibrotic myelofibrosis. And I think your personal story here is a very, very good example. Right? You were given 3 diagnoses in a very short period of time. And that's exactly what I was alluding to before, how these MPNs are really very difficult to tease apart. I'm guessing that you started off with a high platelet count. They said that you had ET, then perhaps your hemoglobin went up, and then they said you got PV, and then maybe they did a bone marrow, and they found that you had fibrosis. A lot of these features are interchangeable and interactive, and cellular, or the cellular phase of myelofibrosis is now called early myelofibrosis or pre-fibrotic myelofibrosis. If I may, John, I think personally, and this could be a subject for a discussion or a debate, I think that in 15 years' time when we have this meeting, no one's going to talk to you about PV, ET, and MF. Those are historical names. They're fascinating. They're beautiful names. They tell us about the disease. They're very descriptive and demonstrative, but they're also very misleading. Look at your case, for example. I think the diseases are going to be classified by the molecular abnormalities, and you're going to have JAK2 positive disease with or without calreticulin, with or without ASXL1, with or without one of the other mutations. And that's going to define the disease course, much like your question was at the beginning, sir, as to, well, what do I have? Not all PVs are the same, not all ETs are the same. In fact, not all PVs are PVs, and not all ETs are ETs. I've had patients with myelofibrosis develop polycythemia after 15 years. That's not supposed to happen. We had no idea what was happening. We thought they should all be transplanted. Now it's very simple. All we know is that for some reason they're having an increase in their allele burden of JAK2. So they're not PV or MF. They're just people with a lot of JAK2. I don't know what you want to call that disease. They started off looking like MF, now they look like PV. It's all about JAK2 in that particular case. And I'm sure it's a lot about a lot of other mutations as well.
I think on that note, it's probably time for lunch. Once again, thank you very, very much, Martin.